Hi all, in this video we're going to see about the factors affecting glomerular filtration rate. So this question has been asked multiple times in various examinations and it's a favorite short essay from Renal. So we'll see more about this. First of all, what is this glomerular filtration? It is basically the ultrafiltration of plasma from the glomerular capillaries into the Bowman's capsule. So see, if the blood flows from the afferent arteriole, reaches this glomerulus where due to the action of the different forces that are present here, there will be filtration of the plasma into the Bowman's capsule and the rest goes through the efferent arteriole. So what are these forces which cause this filtration? We'll see about that. So the different forces involved are, first one is the glomerular capillary hydrostatic pressure. This is the major force which actually favor filtration by pushing the fluid out from the glomerulus into the Bowman's capsule. The next force that is acting is the Bowman space hydrostatic pressure. See, here also we've got fluid, so obviously there is going to be hydrostatic pressure from this side also, and this will oppose filtration. But you can see that the magnitude is lesser when compared to a glomerular capillary hydrostatic pressure. Now, not only this, we've got oncotic pressure also. There is this glomerular capillary oncotic pressure, which is around 25 millimeters of mercury. See, we know that the oncotic pressure as opposed to hydrostatic pressure, they oppose filtration because it is going to draw the fluid into the glomerulus. So similarly, we've got a Bowman space oncotic pressure also. Ideally, you should have it, but the thing is, we don't have any proteins in the Bowman space. So naturally, the Bowman space oncotic pressure is 0. Now, if it was there, the force would have been in this direction, but actually it is 0 because there are no proteins or albumin that are present in the Bowman's capsule. So in effect, the three major forces that determine the direction of filtration or the net filtration pressure are these three. That is the hydrostatic pressure difference between the glomerulus and the Bowman's capsule, and the oncotic pressure difference between the glomerular capillary and the Bowman's capsule. Of course, we know that the Bowman space oncotic pressure is 0. The formula is something like this: Pgc, that is hydrostatic pressure of glomerular capillary, minus that of Bowman space, minus that of hydrostatic pressure. So thus we've seen the forces involved. Basically, these are Stalin's forces. So based on these forces, we can actually get a formula for calculating the GFR, which is Kf into net filtration pressure, where net filtration is pressure, as we have discussed in the previous slide, the difference between the hydrostatic and the oncotic pressures. So here Kf is the filtration coefficient. So we know that the glomerular capillary has got a filtration membrane. So there, based on the properties of this filtration membrane, we've got a filtration coefficient also. So filtration coefficient into net filtration pressure is the GFR. So now we'll move on to a topic proper. What are the factors affecting GFR? So we've seen the formula for GFR. So naturally, what will be the factors affecting GFR? Each of these components. So first we have the filtration coefficient, the Bowman space hydrostatic pressure, the glomerular capillary hydrostatic pressure, the glomerular capillary oncotic pressure, and since there is no oncotic pressure for the Bowman space, we are not discussing that. Then there are two other factors which can influence the GFR, which is the sympathetic stimulation as well as hormones. So now we'll see each one by one. First of all, the filtration coefficient. So we know that you've got a glomerular capillary membrane which has got different layers which ensure that only the substances that need to be filtered are going to pass through this filtration membrane. So large ions or charged particles will not cross this filtration membrane. So Kf is basically permeability into filtration area. So if the Kf is more, it means the GFR will be more. That means no more filtration will occur. If the Kf is less, it means there will be lesser GFR, which means this Kf depends on permeability and filtration area. Now what will permeability depend on? Permeability, usually it increases in presence of hypoxia and toxins. So what happens? Permeability increase means the GFR will be increased. Now there will also be a chance that the proteins are filtered because the permeability has changed. Now suppose there is capillary thickening. In that case, the permeability would be decreased and GFR would be decreased. So these are two factors which will affect the permeability factor, which determines the filtration coefficient. Next is filtration area. So filtration area is basically determined by this mesangial cell here. If the mesangial cell contracts, then the filtration coefficient will be decreased, GFR will be decreased. But if the mesangial cell relaxes, then the permeability would increase and the GFR would increase. So there are certain substances that cause this mesangial cell contraction and relaxation. We'll see what they are. So the agents that are causing contraction of the mesangial cells are angiotensin 1, ADH, endothelins, leukotrienes, C4D4, that is leukotriene C4 or D4, PGF2, PDGF, platelet activating factor, and thromboxane A2. So these are usual substances that we see. All this are usually seen, leukotrienes, prostaglandins, thromboxane A2, ADH, angiotensin 1. These are the substances that cause contraction of the mesangial cells and thereby cause decreased GFR. What about relaxation? Relaxation is caused by substances like ANP, CAMP, dopamine, histamine, PGE2, and nitrous oxide. So these are the factors that is going to affect the permeability of the membrane and thereby affect the GFR. Next, we'll see about the force that is involved. The first one is the Bowman space hydrostatic pressure. So we know that if the Bowman space hydrostatic pressure is going to oppose filtration. So what will happen if the Bowman space hydrostatic pressure is more? Is going to decrease the GFR. Okay. So can you tell me a condition, think of a condition in which this Bowman space hydrostatic pressure is going to increase? A good example would be urinary tract obstruction. So suppose there is a stone here. Obviously the Bowman space hydrostatic pressure is going to increase and thereby decrease the GFR. Okay. Next force that is going to act is the glomerular capillary hydrostatic pressure. Now as I said, this is a very important force which acts on the glomerulus, which favors filtration. So naturally if the capillary hydrostatic pressure increase, the GFR is going to increase. Now whether what will happen to the glomerular capillary hydrostatic pressure depends on the arterial pressure, the renal blood flow, as well as the afferent and efferent arterial resistance. So we will see what are the different changes or how does these factors affect the GFR. So first, the arterial pressure. We know that GFR is auto-regulated between 80 to 200 millimeters of mercury. So between 80 and 200 millimeters of mercury, whatever be your BP, the GFR is going to be remaining constant. How is it so? That is because, as I said, it is auto-regulation. So there are two mechanisms for this. One is the myogenic response and other is a tubulo-glomerular feedback. So myogenic response is the condition in which you see even if the BP increases, suppose the BP increases here, so naturally the amount of blood that is going to come through this afferent arteriole increases, right? But when this amount of blood increase, there is going to be a stretch on this arteriolar wall, right? Now this stretch will act on the smooth muscle of this arteriolar wall and it will cause activation of the stretch activated calcium channels, which in turn is going to act on other calcium channels, that is voltage gated calcium channels, and cause contraction of the smooth muscle. This contraction of smooth muscle means the afferent arteriole is going to be constricted. So naturally there will be less blood reaching, right? So the GFR will decrease. So this is the myogenic mechanism of autoregulation. So here, when the arterial pressure increases, it stretches the afferent arterial wall, opens the stretch gated calcium channels, which in turn open the voltage gated calcium channels. So there will be calcium influx, which in turn causes contraction of the afferent arteriole. There is increased resistance in the afferent arteriole and thereby prevent excess increase in RBF and GFR. Next mechanism for autoregulation is tubulo-glomerular feedback. So again, suppose there is increased BP. What will happen? Usually we would expect the GFR to increase. Now if the GFR increases, there is going to be increased tubular load in the distal convoluted and the thick ascending limb. Now this will be detected by the macular densa cells that are present here. We've got the juxtaglomerular apparatus here, right? So this increase in the solute load will be detected by the macular densa cells, which in turn is going to release neurotransmitters like ATP and adenosine. It acts like a paracrine fashion, and these substances would be released, that is ATP and adenosine, and this in turn would cause, it will have two effects. First one, it will cause constriction of the afferent arteriole, and secondly, it will act on the juxtaglomerular cells and cause decrease in renin. So these two factors will help to maintain the GFR within that normal level, even if the blood pressure increase. Okay. So if the BP increases, there is going to be increased renal blood flow, increased GFR, increased sodium chloride delivery, which will be sensed by the macula densa. It releases ATP and adenosine, vasoconstriction, and thereby bring it back to normal. So what will happen if there is decreased BP? In the decreased BP, what would we expect? There will be decreased renal blood flow, which cause decreased GFR. So this time what will happen to the solute load? It is going to decrease, and that again will be sensed by the macula densa, and this time it is going to release a different substance which is called the nitrous oxide and prostaglandins, which in turn again will have two effects. It will cause afferent arteriolar dilation so that more blood can enter, and second, it is going to increase the release of renin. What will happen if renin is released? It's a part of renin angiotensin aldosterone system. So there will be increased angiotensin 2, and this angiotensin 2 will act on the efferent arteriole to cause constriction. What will happen if there is afferent arteriolar relaxation and efferent arteriole constriction? That is going to increase the GFR. So thus this mechanism will thus help in increasing the GFR in case the blood falls. So if the BP is decreased, it is going to decrease the RBF and GFR. There will be decreased sodium chloride delivery, which will be sensed by macula densa. It will release nitrous oxide and prostaglandins, which in turn will activate this release of renin. It causes release of angiotensin 2, which causes afferent arteriolar constriction, and thereby restore the GFR back to normal. So this is how the GFR, even if the arterial pressure varies between 80 to 200, the GFR remains constant. Now suppose the BP goes below 80, then what happens? Then obviously GFR is going to decrease, and if it is more than 200, the GFR is going to increase. So this is how the arterial pressure, how the GFR varies according to arterial pressure. Second point is renal blood flow. This we know. If the renal blood flow is more, obviously the GFR is going to increase, right? It is directly proportional. And the third point is afferent and efferent arteriolar resistance. Now this also is a very important point. So suppose this is the glomerulus and we've got afferent arteriolar resistance or constriction. So what happens? There is going to be decreased renal blood flow, right? Which in turn is going to decrease the glomerular capillary hydrostatic pressure, which in turn is going to decrease the GFR. Okay. Now suppose the constriction is on the efferent arteriolar side. Now this time what will happen to the capillary hydrostatic pressure? See here the RBF is normal, but because there is a block in the outflow, the capillary hydrostatic pressure is going to increase, which in turn will increase the glomerular filtration. Now suppose it is dilation. Suppose there is dilation of the afferent arteriole. In that case, there will be increased renal blood flow. So there will be increased capillary hydrostatic pressure, increased GFR. Now suppose it is efferent arterial dilatation, what happens? In that case, there will be decreased capillary hydrostatic pressure, so decreased GFR, right? So thus we've seen the three factors on which the capillary hydrostatic pressure, glomerular capillary hydrostatic pressure will work, which is arterial pressure, renal blood flow, and afferent and efferent arteriolar resistance. Next factor is the glomerular capillary oncotic pressure, which means it is going to oppose filtration. So naturally, when it increases, it is going to decrease the GFR. So what are the conditions in which the glomerular capillary oncotic pressure increases? So see, if we know that the oncotic pressure means it is usually due to the colloids, for example, like albumin. So if there is if there is conditions like hyperproteinemia, wherein the amount of albumin is more in the blood, or in case there is hemoconcentration, in that case also the concentration of proteins or albumin, proteins like albumin would be more, in which case the glomerular capillary oncotic pressure would be high. So that is why it is seen in conditions like hyperproteinemia and hemoconcentration. Now what if the pi GC is low?
That means it would increase GFR. So what are the conditions in which you can see a decrease in oncotic pressure? Obviously in conditions where the protein is less, which means hyperproteinemia and hemodilution. So that completes our major factors that affects the GFR. Along with that, we've got two more: sympathetic stimulation and hormones. So we know that, so when there is sympathetic stimulation, we know that we've got the sympathetic nerves supplying the kidney, which releases the neurotransmitter norepinephrine, which will bind on to the receptors present on both afferent and efferent arteriole. We've got alpha 1 receptors present on the afferent and efferent arteriole. Not only that, we've got the beta 1 receptors present on the juxtamedullary cells, which also respond to sympathetic stimulation. So normally, if the stimulation is moderate, it will just cause efferent arteriolar constriction, which means it is going to increase the GFR. But if there is a strong stimulation, it is going to cause both afferent and efferent arteriolar constriction, which means there is going to be a decrease in GFR. So you can just remember, if there is a flight or fright response, obviously your kidneys is going to decrease the GFR so that you can act in that situation, right? So if there is strong stimulation, it is going to decrease the GFR. So on sympathetic stimulation, it vasoconstricts both afferent and efferent arterioles, but in moderate stimulation, it maintains GFR because efferent arteriolar constriction is more than afferent arteriolar constriction. Whereas in stronger stimulation, there is severe vasoconstriction, which means there will be both decrease in RBF as well as decrease in GFR. And this is important for acute blood pressure changes. And finally, there are hormones that can also affect the GFR. So there are vasoconstrictors like angiotensin 2, which you know will act on the afferent and efferent arteriole, mainly the efferent arteriole, which helps to maintain the GFR in case the RBF decreases. Then there are hormones like endothelin, which are especially released during kidney injury, which is a very potent vasoconstrictor. And finally, catecholamines like norepinephrine and epinephrine, which is usually released during sympathetic stimulation. Then there are other hormones which are vasodilators like prostaglandins, which dilate the afferent arteriole and counteract the effect of angiotensin 2. Nitrous oxide, which again is a vasodilator which protects against excessive constriction, and atrial natriuretic peptide, which dilates the afferent arteriole and constricts the efferent arteriole and thereby increasing GFR. So if a short essay on factors affecting GFR is asked, you have to write these factors. So remember the formula. In that case, you will get the first 4 points, in which you have to remember to elaborate on the filtration coefficient and the glomerular capillary hydrostatic pressure, and finally finish it off with the effect of sympathetic stimulation and hormones. So I hope this video was useful for you. Thank you.